Still morning. Okay, gang, we're going to get started. Okay? Good morning, everyone. We're going to go ahead and call the Joint Board of Managers and Human Resource Committee meeting to order. We do not have anyone signed up to speak, right? No. Okay, thank you. So our next item on the agenda is our minutes. You've had an opportunity to review those. Are there any corrections?
Move to approve.
All right. Move to approve by Dr. P, second by DT. All in favor signify by saying aye. Aye. All noes by nay, okay? We're going to move right into our agenda, and the next I have up is for Mr. Whitman to do the update on the annual incentive.
I think Mr. Sullivan's name's on there too.
Oh,
Right.
okay, yes, Steve, I'm sorry. Had to get you.
So, we're kind of between two time frames here. Usually, we have brought the year-to-date performance results to you before now. And in keeping with our traditional trajectory, we brought a discussion of goals to you later. So we are where we are in September, almost the end of the fiscal year, but we want to update you today on where the annual incentive performance levels are trending, where the long-term incentive plan levels are trending. And then after that presentation from Mr. Sullivan, who we've engaged to do that, we will then talk about the proposed goals for 2020 for both LTIP and annual incentive plan. I am not going to talk about the recommended performance levels today. We're going to wait until the year ends, until we have all the information that we can collect about some of these metrics, and then in the November meeting, we'll bring back the recommended performance levels for each of those metrics, the threshold, the target, and the stretch numbers. Okay? So I thought maybe it might be helpful for our two new board members, for Steve, to kind of give an overview of what the annual incentive plan is and what the long-term incentive plan is before he gets into discussion about the year-to-date performance, if that's okay.
All right.
Thanks, Bill. Thank you all for having me here. Nice to see you. And I'm Steve Sullivan with Perlmeyer. I'm a managing director. The whole time I've worked with JPS, I've been working out of our Houston office, and as of about 3 weeks ago, now I work out of our Chicago office. So just a little bit longer flight.
Which office?
Chicago. Yeah. I think.
You missed the rain.
Yeah, the flooding, and they had, 9 days were over 98 degrees and over 95% humidity in a row. So I know. But I am looking forward to the polar vortex this January. So anyway, so I understand from Bill that a couple of you are new to the board and haven't gone through this. So I'll just take a couple of minutes and explain the nature of the variable compensation program that they have at JPS. So as is becoming kind of the norm in, let's say, $750 million, $1 billion and a half dollar revenue healthcare systems, they have established a short-term annual incentive plan, and then they also have a long-term incentive plan, which is multi-year measurement periods. The idea is that, like a lot of healthcare providers in this environment with the insurance industry issues and taxes and all kinds of financial adjustments, they are going through a transformation, trying to turn this organization into something a little different than it's been traditionally, and they're all going through that. I sit through meetings like this, every week all over the country. And so the idea is why you want to have a two-tiered incentive program is that some of the things that this executive team is trying to do is going to take a while. It's complex, you know, bringing about elevating their level of care, elevating their level of quality, elevating their efficiency. Those that don't spend a lot of time in healthcare, basically healthcare is riding on three, you know, tenets. One is high levels of clinical care. Number two is high levels of patient experience. And number three is efficiency, financial and operational. So as a HR committee member, if you were looking at an incentive plan for the first time, you'd look to see that at least one or two or all three of those are in there somewhere, because we call that the triple aim of healthcare, and you want to make sure that this team is aimed in the right direction, which is excelling in those three areas as well as some others. So the longer-term incentive plan is, as currently constituted, is 2 metrics. And in a couple minutes, we're going to go through a document that provides this in a little more detail. But JPS participates in a clinical quality national program called Leapfrog. You can Google it, or you've probably heard about it. So JPS looks at their Leapfrog score, and by the way, that score is what we call a relative score, meaning it compares them to other institutions. So it's not just how well do we do against our own goals, it's how well do we do against other providers. And then the other metric is stewardship, and so cost per adjusted patient admission. And so there's 2 of the triple aim right there, right? One of them is clinical quality and safety, the other one is efficiency, because cost per adjusted admission is all about efficiency. So that's a very solid, in my opinion anyway, a very solidly based LTIP that's on 2 of the triple aim. Their annual incentive plan, and then like many, the idea is that every year we have things that we really have to focus on that are very acute, they're very important. There are things that we need to improve on that are keeping us from getting a better reimbursement from the payers, or keeping us from, you know, getting more patients to come in for whatever reasons. And so the annual incentive plan, which I'm not going to go through all the metrics right now, but we'll go through it in a couple minutes in this pay-for-performance analysis. But suffice it to say that they're measuring quality and some people measures and stewardship and service. So again, heavily based on the triple aim of healthcare. So this program, as it's currently constituted, has been in place now, I think, 4 years. And the long-term incentive plan started out a little different. We were phasing those metrics out, and we've got the leapfrog and the efficiency in there. The idea behind the LTIP is to keep those metrics the same for as long as possible, so that everybody that's in the plan understands what the game is, and they understand what's being measured, and they develop programs and teams to drive higher levels of performance. So if you're on the board and you have a big LTIP payout, a long-term incentive payout, it's probably a good thing, because that means that there were high levels of clinical quality for patients, and there was also a great deal of efficiency, that they made good use of capital resources. Is that going to get us to where we need to be? That's the program as it stands right now. So I came in today to, number one, to talk about what we do every year. We actually do it a couple times a year for JPS. We look at a pay-for-performance analysis. Is this? Yep. So what does that mean? Well, if I'm on the HR committee, I want to know who's in the incentive plans, you know, how much it costs, what does it measure, how did we perform against those measures as an organization, what was the incentive award, what were the incentive awards that were created, and then where does that position us to the market? Are we competitive? The idea is that with this as a tool, this is really a governance tool. If you're on the committee, you can say, well, God, you know, we're doing terrible, and, you know, our leapfrog score is bad, and we weren't efficient, and our, you know, patient satisfaction is low. Why do we have these giant incentive awards? Or the reverse of that, which is, you know, the team's really doing well, they're demonstrating very high levels of performance and achievement on these metrics. Why aren't our incentives, you know, higher? So it's your chance to really understand what's going on and to see if there's anything that's out of whack. It's an assessment tool, really, okay? So if you have this, you're on page 2, and what that is now, I talked about annual incentive and long-term incentive. So base salary plus annual incentive, that's called total cash compensation. That's what this page 2 is. When you add on the LTIP, the long-term incentive plan, that's called total direct compensation, and that comes later. So this is just incentive, base salary and annual incentive. So at JPS, there are 4 tiers of participants in these plans. So tier 1 is your CEO. Tier 2 are your EVPs, there's 2 of them. Tier 3 are like SVPs, and tier 4 is mostly VPs, I think there's 13. So about 23 people all told in this thing. And so when you look at those numbers, like under base salary, so FY 17-18, that was last year. FY 18-19, that's the year that ended September 30th, right? So that is just a sum of all of their salaries of the people, of the employees that are in that tier. At JPS, the annual incentive is 10% of base salary at target for everyone. A lot of organizations you'll see, you know, the tier 1, the CEO is going to have like 30%, tier 2 is 20%, you know, on the way down. They took a little different approach here, and they made everybody's annual incentive plan the same award opportunity level as a percent of base. Where they differ the tiers is in the long-term incentive plan. So the higher the tier you are, the greater your opportunity, or I should say exposure to the long-term incentive plan. So when it says, you know, 91.3 there in the dark green below, all that really, or 87.3, all that really means is on average for total cash comp, base salary was 91 or 93% of total cash. In the next one over, FY 18-19, they're lower. That's because the annual incentive was higher for this last year. It means it's just like a water bubble, you know. It's going to go up or down depending on how big or how small the annual incentive plan is. That's all that means. Whoop. We're back. Down at the bottom there, it actually tells you how many people are in each tier. And it also kind of explains what I just explained, but the writing's pretty small, so I went through it. Any questions on this one?
I might say there's one exception to what Steve explained on the annual incentive plan. Every employee participates in that plan.
Right.
But below the manager level, it's a $500 award based on performance. It's not 10% of salary, but $500. That's the difference.
And while Pearl Harbor doesn't manage that part of the program, I will just give you a commentary that I wish we had more of our, you know, healthcare clients put more of their employees in something where they're exposed to the business results and understand what's good and what's bad, and learn over time how to impact it by virtue of their own performance. So to me, that's a very positive move by JPS to have some variable opportunity based on how well the organization does. So we all share in our success or vice versa. So if you go to page 3, oh, yes.
I may have missed something. On tier 3,
Oh,
what is it? The big jump on the last one. What's the big jump between 184, 185, and 415?
185.
Where are you looking, DT?
The tier 3.
Annual
185.
Tier
Oh,
3.
number of participants.
Was that because of open position and then now we fill them?
Yeah, we had open positions when the last thing was done, and now you filled them with people who got an incentive award.
Okay, all right, thanks.
Absolutely. Yeah, that is a big jump. Good eye. So this is the year before, the one that just ended, September 30th. So if you don't mind, I'm going to, for lack of time, I'm going to go to, okay, so this is the 2019 annual incentive results through September. So on the left half of the sheet, you'll see the quality, people, stewardship, service. And then within that, those speedometers are actually what the metric is. So if somebody walks up to you at the grocery store and says, do you measure anything on people? You can say, yeah. We measure voluntary turnover, we measure employee engagement, and we measure provider or physician engagement. For any of these, you can say that. And so target up at the top of each speedometer, that reflects what they're trying to hit. That's what the organization would like to hit. From an executive compensation standpoint, Over the years, we've worked with JPS, so now when they name a target, that equals about a 50% chance of likelihood of achieving it, right? So we probably have about a 50% chance or so of hitting target. So target is very important because, remember I said how the annual incentive plan is 10% for everybody? If the big dial on the right, which is a consolidation of all the it's a calculation of all the performance levels on the left, if that speedometer would have been right straight up at target, that would mean everybody would get 10% of their salary. In this particular example, though, you see it's 145.57 over on the right there. That means that 100% would have been target. So they're 45.5% above target, which means that these incentive awards they're going to be more than 10%. They're going to be higher than that. Okay, so some organizations you might be familiar with, they just credit you on the last kind of point that you hit. Like, for example, the arrow this year is at 145.57. What they would do is they'd say, well, you're going to get target because you made it to target. Or if the arrow was below a little bit target, well, you're going to get threshold because that's the last break point that you made it past. At JPS, we do what's called an interpolation formula to calculate the size of the award, and what that means is you get credit for every amount that you perform. It just so happens that target is tied into your target level of award. Anything you get above there, though, you get credit for. It's also important to note that in healthcare, mostly what we do is we say, okay, so if target is 10%, threshold is going to be 5% of the salary, which is half. Maximum or stretch is going to be 20%, not 15. It's going to be double. And the reason we do that in healthcare is because if these things are set up right and calibrated right, it's very difficult. You're also adding in a measure of difficulty by having an annual incentive and an LTIP. Very difficult to do well on all that in the same year. So what we say is if the team really demonstrates performance above target and starts moving towards stretch or maximum, we want to give them credit for it. You also need to know that the annual incentive target of 10% and each of the long-term incentive targets for each tier, those have been calibrated to the market analysis that we do every year, so that ideally, if you have a salary that is kind of right at the median of the market and you get a 10% annual right on target, and if your target for the LTIP is 15% or 20%, that's going to put your total direct compensation right around the market median of total cash. So that calibration that's one of the things that they rely on us for, is every year to check that. Okay, so target performance for everyone equals more or less, should equal median level pay in the market, and I'll come back to that in a minute. So any questions on these metrics or the kind of the way we combine them up to create the overall performance or anything like that?
Just the note at the bottom.
It's hard for me to read that.
The exclusion.
I've got it here.
It's the start.
Oh, yeah. So that individual has practicing physician responsibilities as a doctor. And so what we do is we say that we want to run safe out of like laws like Stark laws or anti-kickback laws.
For compliance stuff.
Yeah, and what those laws say is you don't want to have a practicing physician sharing in gains made from driving more business into the system and things like that. So he's just getting measured on it excludes the operating margin metric. Rather, it's going to be on quality service, turnover, and employee engagement and provider engagement. That's all.
That's great.
We had to create kind of a special little annual or special incentive plan for him.
I'm glad you guys looking into that. Great. Good job.
All right. Any others? I'm going to move on. So the long-term incentive plan. So this incentive plan is a 3-year performance period, but they overlap. So that every year, if I'm an executive at JPS, I get a grant of shares that's equal to my target long-term incentive value. So remember I said annual incentive is 10% for everybody? The LTIP actually is like 30% for Tier 1, 25% for Tier 2, 20% for Tier 3, and so on. So if I'm in Tier 2, if I'm one of the EVPs, I'm going to get a number of shares granted to me at the beginning of each year that's worth 25% of my base salary. And then depending on what happens over the course of 3 years, the value of those shares will go up or down. And that totally depends on how JPS performs against Leapfrog and cost per adjusted patient admission. Now, this particular page has some different metrics on the far left. That's because when we first started the LTIP, that was our LTIP. Reduce preventable harm composite and reduce ambulatory care conditions. We changed the LTIP design midstream because the team decided that no longer captured what they were trying to achieve. And so I think it was, well, 3 years ago, we switched to pure Leapfrog and pure cost per adjusted patient admission. But because these are overlapping and they get granted every year, we had to ride out the old metrics. So actually to calculate the incentive award, we had to incorporate the performance against those old metrics as part of the measure. So the way we set these targets is that we don't set them for 36 months, we set them for 12 months. It's too hard to set a 3-year measure in almost anything these days. So we say is, we compare your performance to target 3 years in a row, and we do an average. It's just an average. And so if in year 1 you were 90% of target, and year 2 you were right at target or 100%, and year 3 you were at 110% or 10% above target, the 3-year average is going to be 100. It's going to be the average of those 3 numbers, so right at target. So whenever you see, I'm gonna go to the. This is the LTIP grant that's still going on, that's got 1 more year to go, which will get paid out at the end, a year from now. So if you go back to the one I just had, see they were above target, 116.72 over on the right. And then right now, it's fallen a little bit. They're right at about 100, a little over. That means that 3-year average for each of those 2 things drove it up or down. Don't forget that, yes, sir.
Is there any precedent or justification for weighting that average toward the end of the scale?
Yep, it happens sometimes. It's called like recency or primacy. Like we'll weight the 3rd year more or the 1st year more.
Right.
In certain plans, that's effective. In this particular one, where it's just all overlapping, all you'd really get out of that is the 3rd year of the one you're getting paid on right now, you'd get a little more of that. The 3rd year of the one that gets paid out next year, you'd get a little more of that. So, you know what I mean? It would, over time, it would kind of even out.
Yeah.
So when you see weighting by timing or by year, that tends to be more discrete LTIPs, which are end-to-end, and some organizations have those. In healthcare, we believe that the overlapping ongoing annual grants is the way to go because it's a retention tool. When you do the discrete end-to-end, so I work really hard for 3 years, I find out near the end of year 2, we're not going to make it. You know, we're not going to even be hardly above threshold. I've been thinking about leaving. I'm not going to stay around for the payout. It's going to be small. Whereas in this plan, you've always got another 2 years ahead of you that are vesting. And if we turn things around and when we do the interpolation, we always have a chance to keep improving. So it is a little better retention tool. Yeah, not at all.
When do we look at the targets and the thresholds and raising the bar, so to speak?
Well, that's a great question, because today we're going to look, after we're done talking about this, with what you're going to measure next year. And then I think in a meeting after that, in November, we'll look at where they want to set the target and the threshold and the stretch. So that's all.
I mean, that's the reason I tell you when we're doing it, because we look here and we look at some things that if we hit 200%, the stretch, do we keep that or do we change it? So that's when we do that.
Dorothy has been through the war a few times on this, so she knows. And what Dorothy will do is she'll say, tell me why, 13 is a 50% chance. Show me some data.
What I've learned is whatever Dorothy wants, Dorothy gets.
Well, my point is that, Dorothy actually tries to pry it open a little bit and tell me why you're setting it this low or this high, which is what you need to do as an HR committee member. You need to verse yourself in their financials. You need to learn about leapfrog. I mean, this LTIP, leapfrog and the adjusted patient admission, this is, in tier 1 or tier 2, this is like 2/3 of their incentive program. The annual is just 10% of their salary. This is much more. And over time, this can really be an important part of, it is an important part of the annual incentive plan. So if you're on this committee, you want to work to understand leapfrog as a program and why JPS is where it is, and you definitely want to understand their finances so you understand how they go about reducing the cost of patient admission. Okay. So I had mentioned the last thing we look at is then, okay, given this performance, given these people, given everything else, where do we stand against the market? And so down at the bottom, those speedometers are different. Those are market positioning or compa ratios. And now, so tier 1, that means that it's your CEO. The CEO's total direct comp, which is the salary plus the annual incentive plus the LTIP, is below median. Well, we happen to know that your CEO salary is below median. So there's only one person there, so it's not very hard to figure out why because we have it calibrated so that if the CEO's salary was at median, total direct comp would probably be pretty close to median. Other ones are higher or lower based on mostly who's in the tier. So for example, tier 3, like SVPs, coming out a little higher. I know over the last couple of years they brought in some folks at higher salaries to get them, and so that's a factor there. That's just the paying the freight to get people in this environment. And you don't want to look at this in one isolated year. If you're on the HR committee, you want to keep these that I give you and put like 3 of them across your desk and say longitudinally, how are we? I mean, okay, in September of 2019, Steve showed us this and we were here. The year before that, we were here. The year before that. So keep these things, and you want to look at them one over the other, not just one in isolation. Because we're always trying to get better at having their pay reflect how they perform. The idea is that here at JPS, with stretch or maximum being double the target, if they perform very well year over year and they sustain a high level of performance, like against leapfrog and adjusted patient admission, their compensation is going to be pretty aggressive to the market. And our position is, well, it should be. You're giving them an opportunity to do things that the board wants, that help the people of Tarrant County and make patients healthy. If leapfrog is high, people are going to get healthier sooner or later. So that's a good thing, and everybody wins. What else can I answer on this? DT, that's the fewest questions you ever asked.
Thing that all the staff behind you would say is, do not poke the bear, ever.
Don't poke the bear.
Do not poke the bear. So we're going to move on. Since DT has no questions and you have poked the bear, we're going to move on.
I have one. Actually, anything that we should learn from feedback from the staff, or from recruiting effort that we should, for consideration?
Anything we should learn from the staff?
That you guys learn from the staff or from the people that, regarding to our compensation that we should be looking at to help us do a better job as we set up next year's compensation and all that stuff.
And I'm sorry, did you say anything you should learn or I should learn?
No, you guys can give us feedback that
Oh.
we should be aware of.
Just that you're now starting to, realize the benefit of doing this for several years, where they better understand how to set targets. The first couple of years are hard, but I think that, Robert and Bill and Sharon and Pia and others that help, and people in this room, by the way, that are here, help us figure out what the target should be. I think they're just getting better at it every year, and I think they really try their best to make it be 50% chance. Because you know what, if you say it's higher or lower, sooner or later, it's going to catch up with you. You know, this thing goes on and on. If you're, you know, padding your part, as they say, sooner or later, it's going to come out. So the best thing to do is just do it straight up.
This will achieve what we're trying to get is attractive, but yet still bring out the passion in the people that work here.
I think this brings out the passion of people who work here who are like that.
Okay.
I mean, in healthcare, I go back 25 years. In healthcare, we always had a lot of people that they called them administrators. And they didn't want an incentive plan. They just wanted to get their salary and, you know, do their job. That's all changing now. Healthcare is bringing in people from other industries, different types of folks that are more used to having something like this. And I think from a recruiting standpoint, if you put this program in front of a candidate, like for CEO for that matter, COO, CFO, whatever, you're going to separate the people who want to roll up their sleeves and get to it from the ones who just want that salary. And I think that's a good thing. This is a hard environment, and you need people that want to work.
Thanks.
Okay. Any other questions on that? All right. So why don't we just move right on into the organizational goals updates? Because I know on the agenda it shows PO coming up, but let's just, you're there, just go right ahead into your next item.
Okay. Let's see, it's behind my tab 3. I don't know what page it is on the board portal, but it's actually got a title of Annual Incentive Plan Fiscal Year to Date 2019, which is probably mislabeled.
Yeah,
Yeah.
15 on the portal.
Because this is what, no, that's actual performance.
2020?
So 2020, what page is 2020 proposed annual incentive plan on?
I just have the little packet.
16 of 19.
Okay, 16 of 19, that's where we're going to focus. Can you page me there?
Yeah, I was trying, but it went to,
I can get there.
oh, there you go. Sorry.
I can get there.
That's it.
There we go. This is it. So if you look at that big screen and pay attention to that vertical line in the middle of the screen, that's where I want to focus attention, to the left of that vertical line, because we're going to bring back recommendations in November in regard to performance metrics. What I want to talk about today is what those metrics, those goals might be for 2020 for the annual incentive plan. We would propose that we continue with PSI 90, which is a composite metric of 10 or 11 different indicators. And we've made great progress this year. We're going to stretch ourselves next year and do even better. But I think that's important because that does affect our leapfrog scores as well. It's a very important patient safety metric. In addition to that, we only had one quality metric last year, or this year, right? We want to propose that we expand that quality pillar to include 2 metrics. The second being ED throughput. Big deal. Any patient that we have boarding in our ED over 4 hours is not a good thing. Something from a morbidity or mortality, God forbid, is going to happen to that patient. So we've established a throughput committee that we're meeting every week to talk about improved throughput of this organization. But we want to focus on minimizing the boarding that takes place in our emergency department. And there's a number of things one can do. There's not any one thing. But I think it's important for this organization to keep the eye on the ball of minimizing all that volume that's coming to our ED that ends up boarding on a wall, waiting for a bed to be admitted to. So I think it's a highly important quality metric. It's a highly important patient safety metric. And we'll bring back the baseline of where we are year to date, ending September, and propose levels of performance for 2020.
Let me ask you a question about that.
Sure.
How much of that is quantitative versus qualitative? Because when you mean facility, well,
You don't have
the
any
number of
space for it.
beds that we have is a major
Right.
factor in that number.
It is.
If we've got, 350 people coming in there tomorrow, 400 come in the next day, then the quantitative part of this metric suffers dramatically, because it is just a matter of not having a place to put people.
Well,
So how do we
I agree.
move that dial?
I agree. It's incumbent upon this organization to find ways to move that dial. And Michael and Wanda have been extremely instrumental in bringing a large, multidisciplinary team together. And when I say we're meeting every week on throughput, that's what we're doing. And we're already moving the needle. You need to find a way to optimize the beds that you've got, right? We've only got so many beds. And there's only so much we can do. But I think there is more that we can do than we're doing today. That's what this metric is about, is continuing to keep your foot on the accelerator for that particular metric, meet every week, and find ways that we can minimize. There's some things we can do on the front end from a clinic perspective, being proactive, getting ahead of the game, focusing on those chronic conditions among our connection population. Try to find ways to prevent them from even coming to the ED. That'll minimize the volume. So I think it's a metric well worth considering for next year.
Provider participation.
Extremely participative from the provider section. We probably got at least 10, if not more, providers there every week.
I realize it's critical. However, when we're looking at annual incentives, I'm thinking about how will it impact the overall, everybody, all of the leadership team. I believe it need to be monitored, and I believe it should be reported up to. I just don't think it's one of those for your annual incentive. I think that, you know, if that would be something that could be reported up to quality to keep your foot on the pulse and all of that. Now, that's what I see. Steve, am I off target or?
Well, so I look at these a little differently just because I'm like a compensation geek, but when you set up variable pay programs, one of the really critical things you look at is ability to impact results. In other words, you're going to hold me accountable for 10% of my salary, whatever, and you're telling me it's only going to, you can only earn it if you're able to bring about improvement, you know, in these areas. So I guess my question would be, when we look at the everybody that's in this plan, and I know below VP it's a $500 opportunity, but VP and above it's 10% of your salary. Can all 23 of those people, do they impact this by virtue of their job? Or rather, is this just a small group of people who will kind of make this thing improve or not make it improve? I say that's just a question I have.
I can't think of anyone who's not involved in throughput.
Neither can
I can't. I'm looking around the room on the throughput meeting. I can't think of an executive that's not there.
Well,
Everybody can play a role in that.
Let me probably put it another way with Trent. We only have so many beds. And so now we are saying I'm not saying we shouldn't look at it, but if you already have all the beds full and you have patients, can't close the ER, we're going to have more of them waiting. That's going to be a longer wait that's going to show up. Overall, I know we can do some things, but I'm not seeing this as one of those. Not saying it's not important. I think the ER and nursing should look at it. I think it should be reported up. I just don't see that for your quality to be on your annual incentive right now. How long have y'all been monitoring this? I mean, I know you've been monitored forever.
Yeah.
But I don't remember seeing any report on it, do you?
Yeah, we used to. Absolutely.
Back on the ED committee.
That all started in 2008.
Well, let me just say this. I sit on quality. I would think that this might be one of the quality dashboards that we would be monitoring. I'm not saying it shouldn't be monitored. I'm just saying, I'm just looking at it being on the annual incentive. I know we have a lot of people coming to the meetings, and I know that the physicians, the ER doctors that's working there, the nurses, and inpatient service. That's what I see.
I certainly appreciate Dorothy's opinion, and actually, I think staff's being hard on itself. But I think if we're not hard on ourselves, we're going to be counterintuitive to our own efficiency, and we're going to be counterintuitive to one of our biggest problems. And every time we have a boarding issue, we have patient satisfaction issues, and if we just report it up, I think we're all going to get slightly complacent that we're reporting to all bad numbers. So staff has actually taken on a fairly Herculean task, and the people that will be the most affected by this are managers and above, definitely. It's a hard one, and I agree with you, Trent. If you're limited to a certain amount of beds and 150 people show up in a 2-hour span of time, what are you going to do? But I just think we as a staff commit ourselves to the most difficult of challenges, and that's what I think you all as a board want us to do.
For example, Robert, with your 150 beds that are full, there are ways that you can make some of those beds not full.
That's correct.
Such as early rounds, evening rounds, prescriptions written an hour before dismissal, an area for people where they have been dismissed from the hospital where they can go with a sitter or something like that until they go home. So there are lots of opportunities, and I would take the stance that we keep this right where it is. That's my approach.
What is the average, Steve? What's the metric that we're comparing to?
Right.
What are the average rates that we would expect to see on this metric?
Right.
Well, like I said previously, anything above 4 is never good for the patient, never. And I know that you've got.
I remember days in this organization when it was 12.
Oh, yeah.
I mean,
there's more than that.
It was crazy.
Yeah.
So we looked at left without being seen, we looked at, door to admit, we looked at all these.
We still look at
metrics.
that.
Those are all the crucial ones, but my question here, if we look at this as a standalone metric with these sort of implications in terms of the LTIP, does moving the dial on this, 2 minutes, 3 minutes, 4 minutes, what does that put us in terms of comparison to the average that we think we ought to be compared to? Because I'm trying to scale this as well as I am trying to warrant it. And I'm trying to understand how the scale of it relates to the averages that we're trying to achieve.
How much improvement is worth how much money?
Yeah, better said. Is that a November discussion, or is that a?
Well, depending on whether or not this metric remains as an annual incentive metric.
Well,
But
I think it's-
regardless, it would be a November discussion based on where we end the year.
I think part of the discussion that we can have in November, if it's gonna stay on there, is what do I compare it with? I don't wanna just look at our numbers, because we might be trying to do something, and Baylor All Saint is having 4 and 5 hours. What will be our comparative data beside ourselves?
Relative to what?
Right,
2 other level 1 trauma public hospitals. maybe.
other traumas,
If we can get that information.
we can look at it.
No, we're already pretty
Well,
good.
No, I wouldn't say that, because I had a nephew waiting for a bed for over 12 over there. They was in the ER, Baylor All Saint, they were backed up too. So what do you compare it to, and is there a measurement that we can look at? I mean, do any other hospitals, is this reported out anywhere?
It is. I mean, I think you're at, and Michael, correct me if I'm wrong, 180 minutes is the benchmark for EDs over 140,000? Is that what it is?
This is a national.
Mike, I have Michael, you come on up so we can give you a mic. We didn't equip you with the lavalier. We should have.
But you're still sitting in the back.
So this is a nationally tracked benchmark, it's median decision to admit to inpatient bed. It is a proxy for your efficiencies throughout the house. It's a proxy for how you maximize your bed capacity. It's a proxy for Are you appropriately taking care of your patients and moving them through the system effectively? And we know that there are plenty of evidence-based studies that do show that patients that are waiting in the ED more than 4 hours for a bed have a higher risk of morbidity and mortality. There is an ED benchmarking alliance which looks at a variety of emergency departments across the country. And for EDs that have a volume of over 120,000, the national average at this point in time is 190 minutes. So our numbers are well above what that 190 minutes is. Now, again, it doesn't break it down into, is it a public hospital, is it a private hospital, but it's an ED that's over 120,000 volume, which is ours. So there is a national benchmark that you can compare this to. You know, the other question about who does this impact, it does impact almost every single point of contact in some fashion in the organization, from environmental services to the ability to get patients appropriate appointments upon discharge from the hospital, to our physicians and how they do their consults and get patients in there. And so this is something that really does touch upon multiple areas of the organization and has a high level of patient safety and quality exposure that we have if we don't do better than what we've traditionally done.
Well, let me just say it another way. If we are going to put it in, then we're gonna do some benchmarks. And so I don't want you to come back and say at that point, well, we're a public hospital and we don't have those. So if we're gonna do 120,000 volume, then let's make sure that what we are developing our threshold and target and stretch is looking at something that we can measure. And if we can't get public hospitals, then we're gonna use what we have. And so it's gonna be a real measurement. I mean, but not just on hours. So bring that back next month. Have me some facts and stuff from wherever we're pulling this and what source it's coming from, you know? Because I do understand staying in the ER causes other problems, causes some problems. But I also know on that PSI, you got some major problems that we need to be addressing. So you got two big ones there. So.
We do.
Okay.
Clarification. Are you saying if we can't compare our ED throughput to another?
No, she's saying if,
Go ahead.
and I'll try it. If you can't find other public hospitals to compare to, then you be okay with everybody being in the group, so we can't come back and say, well, this doesn't really apply to us because it's comparing us to non-publics. Right. So if we're in a comparable group, we're gonna be with everybody, or there's gonna be a subsection of publics. But either which way, if we agree to this, we're in for the whole deal.
Well, yeah, because we envision just an improvement over self. We did.
Yeah, I mean, and if we want to do an improvement over self, I think it can be in the department. But if you want to be paid annually, it's going to have to be some type of measurement so you can actually make sure that's volume. And the only reason I'm concerned about it is you have a limit on your beds. And right now, you have a limit. So I just kind of want that for us to know that. It can't compare it to yourself.
I understand. Well, I think we will be, is for the purposes of this discussion, which has been helpful, is I think in November, we come back and you all feel if you are comfortable with what those comparables are, and base it on that. And quite frankly, for us, this could be good deeds gone punished. I mean, we as a staff are putting ourselves out there. We know it.
My biggest concern, Robert, because this is not a single, this is not a single measurable variable at all, because we could measure it more fairly from the staff's perspective if this was a ratio to volume.
Right.
And if it were a ratio to volume, I could make the argument that this, because, I mean, Chuck and I can both sit here and tell you on the last 10 years on this board, we believe this is a crucial variable. I mean, we spent hours and months and weeks on this. And I am not in any way saying it doesn't merit the consideration that you're giving it. I'm only saying, have we really put it into a truly measurable,
Measurable.
fair, objective, metric that says relative to a 20% increase in ED next year? I don't think that's gonna happen, but I didn't think we'd see 40% over 3 years either, but we did.
You're trying to save us from ourselves.
I am. I mean, I think there's a
Well, they
difficulty
both
here.
are, and we get it. And all the arguments that y'all are debating, we have debated staff-wise as well. And I think our conclusion was, we wanted to put forward this measure because one, is so critical, and two, it is imperfect. We get it. So where I think we ought to be with your comments, which I appreciate greatly, your comments, which I appreciate greatly, is come to y'all in November and say, here is the measurable, and y'all.
December.
Yep.
Won't it?
No, it'd be,
It's November, I believe, yeah. And I think what we'll do is then kind of vote it up or down. And we, quite frankly, we'll live by either one, we're okay, because even amongst family members, we have debated this long and hard to where we didn't want to look at family members anymore. So we're okay debating it.
I would also add, how are you taking into consideration code yellows when that happens? and-
Take into consideration.
Code
Code
yellows.
yellows,
Yellow.
when that happens in the ED, and what those patient volume hours really look like. And those external kind of factors that really do weight that particular number.
They do. They do.
Yeah, I mean, when you look at it from the median, I mean, the statistical, what you're trying to do is just put out all the outliers of your days when you've got exceptionally high volume and the outliers where you've got exceptionally low volume, and obviously you get your statistically significant median there. That's why we're not using average here, because that's what'll count for your outliers. And so, our hope is we don't want to be in code yellows. And so a lot of our, this initiation of the regular throughput committee was born out of the fact that we were having multiple code yellows. And what we have seen as we've gone and looked at our length of stay on the house, and we looked at what's called our GMLOS, which is what would be a national benchmark, comparatively to our acuity mix, there's a little bit of an imbalance there. And so this is an opportunity for us to look at our utilization patterns, our appropriateness of care, ties back to some of the comments, certainly DT and Dorothy, you had even at the last meeting about, how do we do utilization? How do we approach all those aspects? And this affords us an opportunity as a proxy measure to begin to encapsulate a lot of that work.
One more question. Is, if I'm reading this correctly and your intent correctly, am I measuring the same thing when I say decision to admit time? In other words, the decision to put you in a room, is that the same as the time I get into a room?
No.
Okay, so then,
This is decision to admit in a bed. This is not decision to admit. This is actual time from decision to admit that patient to the time that patient gets in a bed.
and a variable in that decision is whether or not there's an available bed, right?
Correct? Absolutely.
Yeah, this is
So it's not-
physically in a bed.
Okay, so it's not, it is, I mean, it's an apples-to-apples comparison. It's not a circumstance where the doctor says, well, I'm making a decision to admit, and.
They don't get a bed.
Yeah, that doesn't
No.
They
count.
say, well, I'm
That
sorry,
doesn't
an
count.
hour and a half from now, we can.
Counts when they're in the bed.
Yep.
Yeah.
Okay,
Yeah.
then I'm
and this
measuring it.
exclude observation patients.
OBS is not
OBS
included.
is
OBS is
not
not included in this. This is just the ones that are decision to admit.
Urgent care is not included in this.
From a exec comp standpoint, I think the committee's on the right track, that when you can, you want to see a relative measure as opposed to an absolute measure. In other words,
Always.
how do we stack up? And I think Trent is on the right track
Yeah.
with wanting to look at volume too, because I deal with inner city hospitals in other cities, and some of them are, would you say 120,000 a year
Yeah.
come through?
So-
Some are half of that.
We're
some-
higher than that.
We're three
I just
fifty
read
a day.
that.
120,000 is the compare.
Oh, okay. But some are, some are very low and some are very high, and you can imagine that has a huge impact of it. I also I wonder whether or not you can factor the data by CMI, by case mix index, in terms of the stuff that's coming in the door versus, simple stuff.
Well, you're not going to admit simple stuff. right?
You know what I mean?
I do.
Yeah.
I do.
We don't get simple stuff.
And I'd be very cautious about putting CMI data on an incentive plan because you don't want individuals
Gaming
to,
that, yeah.
to game the system in a certain way from a CMI perspective.
Yeah, I mean, we have some clients with it in there on their LTIP, actually, and I think we've
Yeah.
gotten to the point.
It's a
with that.
challenge.
It's a challenge, you gotta stay on top.
You do.
So I agree.
Courage, guys, honest to God, I really do salute the courage. And I'm on board with it, I'm just not sure that we're not cutting our
Well,
nose off.
we've got more than a couple of type A personalities that, want to push the envelope and do better each and every year, and it's challenging. We get it.
Zim, you,
Appreciate the discussion.
I guess being new, have we been measuring quality, or is this something we're just starting to do brand new?
no, we have quality.
Always been measuring this.
So I guess my question is, if you've been measuring this for 2 or 3 years, you ought to have some kind of data as to whether it's a good thing for the staff or a bad thing for the staff, right? That's what we're really discussing here, isn't it?
Right.
Is this something that is fair to the employees, or the management here, versus something that's not? And if we've been measuring it before, we should have some information that tells us whether this is.
Yeah, no, I appreciate, it's not the information that we lack. We have the information. The question is should staff be incentivized to get that person from the ED, from that process, and into a bed? All the data's there.
But Zim is right on, we have the data. I've been serving on the quality committee for almost as long as I've been on the board. I have never seen this come to that quality committee as a report.
Well, remember, Dorothy, we used to have a scorecard that was over 80 metrics. That was, I mean, there's 1,000+ metrics we could measure every single day. So you gotta choose the most critical ones, but I think there was a metric about that on that scorecard.
Well, let me just say it this way. Here's what I would think as coming to here to be put on an incentive plan. There should be a history of it. That would be something that you would be showing. Here's where we've been monitoring, here's where we've tried to go and all that. But let me just say it another way. I have been on the quality committee since I've been here. Now, I'm pretty good at data. Now, I don't remember the 80-page score sheet because it shouldn't be.
Not 80 pages.
Okay, I don't remember the score sheet having, a scorecard having that many. And so I would just think that if you're bringing it here, you should have some history on it so somebody could look at it.
I'm just saying, we keep asking a question as to whether this is a valid metric or not, and a fair metric, and yet we ought to have something that says whether it's that way or not. That's all I'm saying. Now, one other thing, can somebody define for me threshold, target, and stretch?
Steve, you want to take a stab at that?
Sure, I mean, so we have to, like Bill just brought up, our organizational scorecard. Well, this really is not an organizational scorecard. This is just cherry picking as few as possible that are critical for us. And so threshold, target, and stretch are just levels of performance that will yield different levels of pay.
The reason I ask is that when I was in business, threshold was the minimum that was acceptable. Target was a goal.
Yeah.
And then stretch was if you went over that goal. And yet I look up here and I see a target of 98 and a stretch of 88, and I don't understand that.
That's because with the PSI 90, 1 is where you sort of want to be, but any number lower than that is exceptional.
It's like a golf score.
Or mine go higher.
Not your golf score.
Low is good.
Mine go higher.
Now, go the other way on this one.
That's a reverse.
Okay, so it's an
It's a
index.
reverse one.
Okay.
Target is your target that you're trying to hit, and that's associated with your target level incentive. Anything below or above that, your incentive will go up or down.
And one other question, is this a team measurement? In other words, the entire team gets it, or if there's a
Oh, yeah.
player?
The whole organization.
Oh, okay, that's all I need to know, thank you.
And back to the discussion about threshold, target, and stretch, Steve's given us some philosophies around that 10% of the time, you're gonna hit stretch. 50% of the time, you'll hit target. 90% of the time, you'll hit threshold. That's how you kind of establish those performance metrics.
Can I just throw something out, totally different? Why don't we look at surgery, start time? Because if start time is not correct,
Well,
there's a
look
lot
at
more.
infections, post-surgical infections.
Yes, all that stuff, but
I mean, I think there's so many to choose from, but I don't know if all of them reach all the disciplines that this one does.
Yeah, surgical infection would not.
No.
Would not, it wouldn't
No.
be, it's a good one, and it's good, but it wouldn't be across the board.
And PSI 90 is a predominantly very heavy surgery metric.
Oh, yeah.
Very heavy. And so it takes into account a lot of things that occur in the post-operative period.
Correct.
Sepsis, infection, DVT. And so we wanted to find another metric that would also help involve the rest of the organization.
I just want to state, just when it comes to incentive plan, that I will always go towards the harder to achieve. So I like the fact that we're judging against ourselves, but I do like the fact that we can compare to, seems really loud, that we can compare and use as a comparison, maybe to set the threshold, target, and stretch, or to at least evaluate where those goal lines should be. But I'm a huge fan of judging on ourselves, because that's, in this instance, seems to be the most difficult metric.
Well, we want to thank y'all because your opinions have been very identical to staff. They're all over on this one, and we're trying to figure out how to do this one right. It is a tough, not necessarily a wrong or a right, but I'm proud of the staff. Whether y'all go with this or not, I'm proud of the staff by putting themselves out there. They did not take the easy route on this one. To Trent's point, can it be measured properly? We gotta work that out, but I'm really impressed with the team because we said we'll put ourselves out there, right or wrong.
One takeaway, Robert, is to elevate it to the quality committee reporting.
No, it's gonna be there.
I mean, you know, that way that question's out of the way, because this data exists and we've seen it many,
Yeah,
many
sure,
times. It's just a
sure.
question of what has it done over the years?
Exactly, and I think that's where we are, Trent. We've seen this, y'all have seen this. Now the question is how level of accountability do we hold? To Michael's point, you put this on this, EVS changes their attitude. Our doctors, our hospitalists, it is across the board. So I don't want to talk it to no pun, don't want to talk it to death, but I do think that this warrants this kind of discussion.
Okay. Any other?
Point number 2. Moving right. Yeah, our second point in today's debate.
Michael, don't go away, don't go away.
I don't think so.
We're recommending that we keep the same two metrics, HCAHPS, which is a nationally recognized survey where we can compare ourselves among other people. And there are 10 questions in an outpatient survey that we conducted this year. We're going to come back with new performance metrics in November, like I said. But in the HCAHPS, we have historically measured our percentile ranking for top box score or overall recommendation. We changed it this year to focus on the 10 dimensions within the HCAHPS survey. And we used as a benchmark the national rate of improvement for each one of those dimensions as measured by our vendor. For this coming year, we've got the same questions, right? But we want to move that up to the 75th percentile. We want to say we want to improve each of those dimensions at least to the 75th percentile. Not the national rate of improvement, but the 75th percentile. Again, type A, doing more, but we'll bring back more information in November. The outpatient survey, they're the same 10 questions, and we set a improvement over self of 0.3 last year. For every question in the outpatient arena that improved 0.3 or greater, we got credit for it. We're going to recommend 0.6 or greater in 2020. Okay? Any discussion about service?
Yeah, I know we're gonna keep the same questions. Now we're just going from point 3 to point 6?
Correct.
Okay. So when we first started doing that, what was our measurements? Because this is a,
We used to participate in CG caps. CG caps was kind of like H caps, except it was an outpatient focus. So a lot of hospitals and healthcare organizations are moving away from CG caps.
okay,
They're no longer required to do that. And they're looking at specific questions that are meaningful to our patients based on really the actions of the providers in the clinics. And we're focused on those 10 questions that do have some national comparison, although we don't have a database to compare to. But we think those are meaningful. So when you look at a 0.3 rate of improvement, that's why we got to stretch this year, right? We focused on those questions. How do you improve those questions? If you look at the national rate of improvement for HCAHPS, there's a national rate of improvement for each dimension. So we just took an arbitrary 0.3. So we got that out of the way. Now we're going to double it. We're going to try to double that performance in 2020 from where we were in 2019 for each question.
I guess when we first started this, because I'm looking at 2018, I have all of it up here. It was on percentile ranking.
That was CG caps.
That was CG caps. So we aren't using those anymore.
We're not doing CG caps. And in November, as I told Mr. Bowes in our conversation before this board meeting, or committee meeting, we're going to bring back how we're comparing nationally from an HCAHPS perspective. That was one discussion that we had several months ago at this committee. Well, we kind of lost sight of percentile ranking because now we're focused on improving dimensions, right? We haven't lost sight of it. We just haven't done a good job in reporting that information to you. We'll bring that back in November.
Okay.
But Laura has been bringing, and now Rob, been bringing this to the quality committee.
To quality.
I mean, we've been looking at
Yes.
We've been looking at those numbers, but I do not remember us looking at any quartile or percentage or anything. It was just that did we get the elements?
From an HR committee perspective, we've been focused on dimensions and have not been reporting percentile ranking. But we haven't lost sight of what that is.
Okay, so what you're looking at now is just keeping the 8 questions, and then we're just gonna increase the difference between the measurements from 0.3 to
For a specific question, if we do not achieve a 0.6 improvement year over year, whatever these performance metrics we bring back in November, we won't get credit for.
Okay.
If we want to improve 3 questions, 0.6 or greater, and we only achieve 0.2 or 0.5 in this case,
How did you decide on the number 0.6?
It's arbitrary.
Maybe that's my.
it's arbitrary.
Okay.
It's twice the rate of improvement from 2019.
Right.
Okay. Okay, maybe, okay. Because I looked at ambulatory, they got 8 out of 8, and so now.
8 out of 10.
Eight out of 10. Well, their stretch was 8, so they've got all those. So I just kind of want to say that every year when we are looking at changing this number, I'm losing something. I'm not seeing the movement that, how I started with percentiles, and now I'm on dimensions, and getting out of 8 to 10, you get 8, and now we're changing.
Can I ask a quick question?
Yeah.
What was the decision behind ending the ranking percentiles?
We felt that we had hit the 75th percentile, and to move it from the 75th percentile was a huge ask, right? It's sustaining the 75th percentile that became even a challenge. So how do you differentiate between threshold, target, and stretch when you're talking about very, very small numbers?
Minuscule.
So if you focus on the dimensions and improving the dimensions based on a rate higher than the national rate of improvement, our thinking was that you're going to increase your percentile ranking along the way as well.
Is there a need to have like a trigger, like we never will go below this percentile ranking? If we do, then none of it matters? You know, I'm trying to hear
That's
what,
certainly possible.
Like
I don't
established
think we've
75
lost
as
ground.
a threshold or some number as a baseline.
yeah,
Yeah.
some number that's
That's-
not, you know, that's not acceptable. We have to stay
Right.
at that or above to be in the money.
Yeah.
Some you can,
Makes sense.
it's just a design feature. It could be like your threshold.
Well, it's possible, but if you look at it from the perspective that if you're at the 75th percentile now, and you even improve one question or two questions beyond where you are today, you're still going to maintain that ranking, right?
Yeah.
What you're saying we're not focused on is the number of questions that we're not moving or we're losing ground on.
Yeah.
Okay. That's something we can bring back in November as well.
Okay, anybody else have any questions?
Bill, when we come back in November, can we see how we compare to some standard, whatever that standard is, national, I
Right.
mean, you tell us, but something that gives us some comparison other than just against ourselves?
Correct. We'll do that.
Okay.
The next one is people, first-year voluntary turnover. Last year, we focused on voluntary turnover total, period. Our thinking is that we need to pay special attention to those folks that we bring on in the first year of employment. Our rate is not where we want that rate to be. If you look at this as a baseline rate of 33%, that's not acceptable. That's costly. That's bringing the right people in. That's having training them for whatever period of time and they leave before the end of the year. It's extremely costly. So again, we want to challenge ourselves to focus on keeping those folks we bring in the door, selecting the right people, making sure they're here for longer than 1 year, hopefully longer term than that. And there's national comparisons about where we should be for first-year turnover.
When you have an employee that voluntarily terminates, do you have an exit interview with them?
We do, but we can't require it. We try to solicit that information. We use that information, but there's not a policy that requires, nor can we require, every employee to submit to that exit interview.
Yeah, I don't know exactly how this equates, but in MedStar, we had a huge turnover rate, particularly first year. And what we found is that the turnover rate was to go to a better position based on their experience as a medical person, either to be a nurse or to go to the fire department or somewhere
Right,
else.
right.
And we thought, and there was no way we could figure how to do an interview to bring a new employee on and get that factored into the equation. So some of this you just have to live with and hope that you can
Some
find a
of
way
it
to.
you do. You don't want to prevent them from advancing, right?
Yep.
And we have a similar situation, and I'm not going to say it's totally equatable to what you described, but we have a high number of sitters, over 100. And those folks are constantly looking for ways to advance themselves. And any opportunity within the organization or external to the organization, they're going to leave. We've got to replace them. So we got to factor that in as well.
Yep. Well, it's a difficult, turnover is a difficult situation in any organization. Some organizations are more stable in the employees that they bring on, but I think in this field and in places like MedStar, it's more of a turkey shoot than anything scientific you can do to keep it from being bad.
The other two metrics we'd like to continue to measure is people and provider. And we have just concluded our provider survey and our employee survey. We will have the response and the outcome of that when we come back in November, but we always want to keep our eye on those two metrics.
Do you see that, based on, because we've realized tremendous progress in both of those, especially position, over the past 3 years. do you see not only keeping those metrics, but do you see the ability to push those metrics higher? Do you recommend this?
Possibly, depending on how that survey turns out.
Okay.
We built in a factor this year that we might have some slippage. Our vendor keeps telling us, you can't continue to push that envelope. You're gonna have some slight slippage. Do not be alarmed if you do. We kind of built that in this year, but time will tell whether or not we realize that. But we'll continue to push that envelope.
Okay.
Stewardship, we want to continue with the modified cost per adjusted admission for anyone below the level of VP. And we want to focus the VPs on operating margin. The leadership team has the most influence on revenues and margin, and the other individuals in the organization can do a better job of controlling cost.
Not including debt service in the overall pro forma, right?
Not including debt service, and Sharon has a very specific formula of how that will be calculated. Now, I would like to propose that academics and population health not be made a part of the annual incentive plan. I've spent some time talking with Steve Sullivan, and his point is well made. Again, back to the example of the type A personalities want their areas of responsibility highlighted, focused, everybody working on them. But in reality, there's probably no more than 2 or 3 executives on the leadership team that can actually influence or control these 2 goals. We want to put them as an organizational goal. We want to find some committee of the board to bring this information back to and realize the performance that we're achieving or not. But I would recommend that we not include them in the incentive plan.
What do you think about moving toward more value-based type thing instead?
Moving to more value-based, I think it's inevitable.
Because it's shifting, it can cover both of those.
I think this
in a different way.
organization is, we're farther along than we were last year, much farther along than 2 years ago, but to make that as a goal for this year, I don't think that we're ready to do that.
Ready?
Not ready to make that an incentive goal,
Still not getting paid that way.
right?
Right. Outcomes.
But the ultimate goal is outcome. But it's very subjective at this point.
Well, and how they get reimbursed as well has a lot to do with it.
Right.
I can see where academics may not be that important to the overall incentive plan, but explain to me how population health isn't.
These particular, it is. It is, Roger. There's no question about it, and that's why it's here, because we felt strongly that it is. It affects patients, but in talking with Steve and in speaking with Dorothy, and I'm not intending to say they're the reason that I'm recommending we pull them off. There's only 2 or 3 executives that can influence population health. That's Karen Duncan, that's Joy Parker, and that's Zelia Ball.
As it's being measured here.
As it's being measured,
The concept of population health is excellent, and if they had some kind of an aggregated measure of net outcomes or something like that, that's what you're looking for.
Sure.
But they don't have that, and so they've got these very finite, and they're kind of running out of room on this card, basically, and
But is there a way to increase the criteria for population health?
raise it up
That's
to be
more
strategic.
encompassing for everybody to where it is still a measure?
Oh, yeah. I think we do need
Because,
a
I mean,
measure
I think
for
as an
that.
incentive plan, that's a bar you want to see moved higher.
it is.
It just has to be measurable, though.
I understand that,
Because-
but before we just axe it, I would rather see what we can
We're
do.
not asking that category, but these 2 measurements, they can come up with a different measurement. We talk about let me just do one I was thinking about on oncology. One of the deals on that is we get our patients at late stage, okay? Well, maybe we ought to be looking, could we identify them earlier? And that would bring in your primary care providers and other folks into it. And that would be, we would be looking at reducing the identifying the cancer cases early. I know population health should be there. I just think these two measures are
Well,
limited.
if the metrics need to change, I'm totally fine with finding one
That's
that's
what
more
I'm
broad.
trying to say.
But as far as just taking population health off the annual incentive plan, I'm kind of against that.
Okay.
Finding a broader measure that we can indeed measure is the challenge.
What about number of connection patients with primary care physician appointment, you know, something that tells that we're actually putting our connection patients in primary care physician care and they're actually getting it?
Yep.
Something like that, to me, is a more global sort of population health measurement.
Okay.
I don't know the extent that we can do it.
Well, it's hard to move the needle on infant mortality in a year.
Right.
Putting just on us, because there's so many other
Yeah,
variables
there's-
in it. But the-
Just as an aside, in talking with Michael, there's sort of the trend to get rid of population health as a term.
To change to
And
what?
call it outcomes. That people can understand outcome a whole lot better than population health, because there seems to be many opinions about what exactly is population health. Whereas outcome is
Yeah, it's like
relatively
mixed use in my world. It's like,
Right.
okay.
Sure.
Okay.
What's your
I
doctor?
think-
We don't,
That's just as a
that's helpful, very helpful.
You know, I'm comfortable with the term population health because you're trying to improve the population's health. And the only way you can do that is doing some of the early screening. Your JPS connection that we put in our program, how many of those are seen by a primary care within a year? I mean, we have some measurements that would affect everybody. It isn't that we don't want it on here. I just think the matrix need to be.
If we can find the right measurement, we're for it too, and we're not for dropping it.
No,
We'll
no.
try to figure that out.
Okay.
Again, the more difficult, the higher we raise that bar.
Right.
Oh, sure. Without a doubt.
I think the more providers become, as they start to get reimbursed for outcomes, then I think it'll become more measurable.
Yeah, absolutely. So,
But I think there's some opportunities for us to find a more global measure.
Bill,
We can
is,
bring that back as well.
when you look at academics, for example, and trying to find quality metrics under that category, does it say something to the need to potentially go back and look at the weight of academics and their overall score?
The weight.
Yeah, because we're giving academics the same level of importance here as we give stewardship. And I'm not
Yeah,
sure
and-
they're the same.
And that's really, that's not something that we're recommending. It's on here because it shouldn't have been.
So just take the
That's
category out
still in
altogether.
discussion about what those
Right.
weights should look like, depending on how many pillars we're measuring.
Uh-huh.
I'm not in a position to recommend any weights right now.
So we would then, we would redistribute that 10%.
Absolutely.
Right.
You reduce those two pillars, you'll redistribute those weights among the four that remain. We come back with a population health global metric, we'll redistribute those weights as you see them here. And the reason we're bringing this to you before we're ready to talk about performance metrics is we want to be in a position to begin cascading some of these goals to the organization and having them work on them. Still waiting till November or December of every year, then you're 9 months or 90 days into the year.
Do you think it in any way potentially negatively influences our effort to become integral to the med school?
Taking away academics?
Yeah.
No,
No.
I don't think
I
so.
don't
And
think
our relationship with the medical school is so strong. And I can't tell you, every day I hear, oh, you better be doing this. We're doing it. And we have more academic appointments than anybody else.
Okay.
We have more people in key leadership. And what has always been the factor from the very beginning, and not being trite or boisterous about it, that medical school will succeed with a link to its public hospital, and their leadership knows that, and they've stretched out immeasurably to Tricia Elliott. And also, your caveat of concern is good, but what Tricia Elliott has done and what Grant Fowler and our chairs have done has been pretty phenomenal. We are cemented, I would feel. And Tricia, you can correct me if I'm wrong, but every time I meet with the TCU team, they're amazing about, we need you guys, and thank you for having, how many appointments do we have?
We're upwards now over 50, almost 60.
Yeah, we're almost at 60 appointments to the medical school. So some of the folks that say we're not doing as much, or you got to protect yourself, may not know the fact, not you, I'm saying the community folks that want this high profile, we should have a building on TCU's campus. It's a little bit different than what we're actually really doing. Tricia, go ahead.
Just wanted to just put your mind also additionally at needs compared to the two metrics there too, because the way we also wrote them are opportunities for collaboration. So oftentimes these educational workshops and the grant submissions, we look forward to partnerships with our actual academic centers in the area.
Well, that's good.
All right.
Yeah, don't be messing with Tricia Elliott either. She's tough.
She's polished.
She got nothing over a horn frog, let me tell you.
Okay.
Nothing over a horn frog.
Yeah, she'll take him to task.
All right. Are there any other?
Don't worry about it, don't worry about it.
I'm leaving that alone. Is there any other questions on the goals? Okay.
On the LTIP, we're proposing that we leave those metrics as they are. That's the purpose behind a LTIP plan. It's a 3-year plan. We don't need to be changing those each and every year, but validation that this committee believes the same.
All right. Do anyone have a question for Bill or for Steve? All right, thank you.
Thank you.
Okay,
Okay,
Thank you all.
be ready for November.
we will.
Okay. All right, I think next on the agenda, I have, okay,
It's very good training.
okay, thanks, okay. We have a couple of close item deals that I gotta get to. Okay.
Okay, we are 1/3 done with the meeting, so.
Yes, we are. We're almost done.
Wait a minute, and that was gonna be quick.
Now we're gonna get into the meat of the subject. Yeah, the whole balance of the table's wrong.
Okay, good afternoon, everyone. What I would like to do this afternoon is provide you all with a update on human capital relating to turnover by job class. What you have before you this afternoon is basically turnover by job class, but at the very top, we do provide a breakdown quarterly of what the turnover is looking for within the organization. As stated, on a consistent basis, we do benchmark our information against Saratoga data. And one of the key metrics that we did focus on for this year was total voluntary turnover. As you can see, for fiscal year 18, we did end the year at 13.06. And as you can see, for each quarter, we have been trending downward with that voluntary turnover. So for quarter 3, we did close voluntary turnover at 11.81. Again, our goal is to reach the benchmark for Saratoga, which is 11.20. One other key metric to focus on too is our vacancies, and that's key because with our vacancies, we want to ensure that we are hiring right, that we're bringing the right fit to the culture. And of course, you did see a slight trend upward with our vacancies increasing for the year, and that was due to us having to hire for more sitters. And this was to make sure that we were reaching our regulatory requirements relating to patient care as well. If you look down at the very bottom of the document, of course, this provides a breakdown of our turnover by job class, and this is the data that we look at on an annualized basis. And so for the organization, again, looking at voluntary turnover, on an annualized basis, 12.27, that's where we're trending at for the quarter. As stated, this is our human capital looking at turnover, which is key to the organization. And this is just giving you an overview of how we are focusing on turnover for the year. Are there any questions relating to this document?
We have a couple of areas that's for their total turnover, and that's for, is unusually high.
Well, we can talk about executives and executive turnover, and it's a challenge. We have a small, obviously, it's the smallest group, and standards are high. I think what you do in an interview process is you try to vet the best you can. I do think that in those kind of high-level and key positions that sometimes have 2,000 people reporting to them, in a CNO's case, or in some cases where you have over 800, where you have a plan ops division and you have an EVS division, the challenges that you have there are more glaring. So I will make hard decisions. This is a team that is, by standards of the community and standards of this board and standards of this organization, a demanding organization for reaching results. And when we either don't reach those results, that person's not going to have longevity. The other thing that I am probably different at is it is very important to me that the team not necessarily all like each other, but they all get along. And if I've got somebody that says, I can't work with so-and-so, or every time I have a meeting, it's kind of productive, those are weighty to me. And I'm going to consider that. Again, I don't have, it's a thin line. I don't need everybody on that staff liking each other and all having Thanksgiving dinner together. What I do need, though, is a protocol and a process by which they can get along. So we have made changes. And I think that's the read I get from the board of the demands that you all have. I don't like the turnover rate. I don't feel comfortable with it, but I also feel comfortable with the best performing team I can possibly have. And some of those high-level positions are going to change.
Okay. Is there anything that the HR committee could help you with, or
I think
anything we could do?
Sure. I mean, I
Kinda
think
help
we
with that?
constantly, and Pia and I talk about this often, we constantly try to figure out about how best we keep people in the organization. We have now gone to a process by which we provide executive coaching to people who are not either getting along or trying to get along. We work on that. So I think Pia's been, and Pia, you can speak to it as well, but I think Pia's been helpful and the HR team has been helpful at trying to do everything we can to keep somebody on the executive team.
All right.
I'd like to see how much of the involuntary turnover are people that have been here less than 5 years.
Throughout all categories?
Well, no, on executives specifically, the one we're talking about right now.
Less than 5 years?
Yeah, right, and maybe 3 years is better. You guys tell me, but I'd like, because it would be one thing to me if I saw that turnover, that high rate of turnover were people that have been here 10 years or more.
Right.
Than people that have been here 2 years.
Right.
Because a lot of that's just, we learned that they don't fit. As opposed to somebody who's been here loyal and done a great job for a long, long time, a whole bunch of those start leaving. To me, that's a different,
I agree.
a different issue.
Well, and anecdotally, I can tell you that the greater percentage of turnover is going to be in your 3-year category.
Okay.
They're not going to be your long-term.
That's what I'm
We'll get the stats on that, but just to my memory and knowledge, they're going to be people that did not work in the organization. Just the interview process was different than the reality. Okay. Or what we have found is we find executives, and we even find vendors that do this, will constantly underestimate JPS and its challenges. And they will get in and say, oh, I can do that, I can do that. And then they find when they're here the harsh realities of a challenging and complicated place.
It kind of goes back to what Amanda was saying, though. You know, do we have the right criteria in terms of our search
Yes.
characteristics? And if we don't have the right criteria that we apply to our professional search firms, we shouldn't be too shocked that we end up.
That we're getting that. I agree. I agree.
Okay.
We'll have that to you.
Okay.
Okay. Anyone else have any questions on it? Comments? Okay, all right. I think that's all I have for opens.
We have a policy.
Oh, a policy, I'm sorry.
Personal leave.
Didn't flip back to my, okay, so what's your policy?
HR 3200 personal leave,
Oh, okay,
and there are not any changes to the policy.
okay, so, okay.
Why is it on the agenda?
Huh?
Why is it on the
It
agenda?
has to go
It
through a
has to go
process
through
of being approved. When it expires, it has to be
Oh,
approved.
this
if
one
there are no
expires.
changes.
Okay.
Okay. All right. It's motion by Dr. P, second by Roger. All those in favor signify by saying aye. All right. Pass. So we do not have anything else, but we do have a couple of close item. Close, in closed session items, okay?
You mean with 2/3 done?
We will reconvene in open session at, I think that's 1:10. There being no further business.
Suppose I would state that we never officially went into
go-
instead of saying.
Okay, all right, okay. There is no further business, so therefore we are closed.